their hands up for you are Matt, Jenny, Sue, and Remco. And we'll do our best to capture your feedback and make sure that we capture that accurately. With various other people in the room, one thing that I just wanted to mention first is that one of our residents, Mark, would like to film the event. If anyone would prefer not to be filmed, please just let me know. That's absolutely fine. It's up to you if you would prefer not to be. Let me know, and we'll sort something out so you can sit at the table where you're not in view of the camera. So just tap one of your facilitators and let us know, and we'll sort that out. Okay. Couple of other bits and pieces of housekeeping that I'll run through. In terms of the venue, we're not expecting a fire alarm if there is one for a fire on either side. We're here for about 2 hours, and it's not a long session, so we won't have a formal coffee break. But if you need to get up at any point, stretch your legs, take a break, toilets are at either side, feel free. If you need to take a few minutes, whenever you feel the need, that's fine. Okay, that's my housekeeping. I'd like to introduce a few more people who are here to help us with discussions today. I'll just go around and hopefully get everybody, wait with me if I miss you. These are people from the Trust and the CCG. So I have James from the CCG, from Sutton and Merton Hospital Trust. I'm so sorry. James. James Bly from the CCG and James Marsh from the Hospital Trust. Apologies, James's. That's my mistake. We also have Mrs. Lisa, who's from the Trust. She is from the comms team, is here helping out with the events. I have Andrew Merry, who is the chair of the Merton CCG. I also have Lucy, who is from the CCG. She's going to help out with the note-taking today as well. And Ruth. There's so many people on my right. This is Ruth Charlton, who is also a clinician from the Trust. And Andrew from the programme team. Is there anybody I've missed? So I was just listing people who are here from the CCG and from the Trust. Who's your local MP? Who's here to participate? So that's a kind of quick round of introductions. The teams from the CCG and from the Trust are here primarily to listen to them, and that's why they're sat at your table today to listen to you. We will provide a little bit of information to give a summary of the case of change and the issues paper. There are copies of the issues paper on all of the tables, but what we don't want to do is spend a lot of time at the front talking at you. We prefer to spend our time talking to you at the tables. Just in terms of how we'll do that, what we'd like to do as much as possible, there's quite a lot of views, to make sure that everybody has the chance to speak. So we'll spend most of the session working at tables in small groups. What that lets us do is to hear from more people in the 2 hours that we've got. So that's what we'll aim to do. And there are a few kind of basic principles we'd ask just when we're working at tables. All of the things that you would ordinarily do, just being considerate of others, letting them have a chance to speak. The facilitators will be taking notes on the table, and we'll publish all of those notes. So bear with us if we ask you to repeat things, if we ask you to help us capture place names or technical terms. That just helps us make sure that we've accurately captured what you're telling us. If you want to broadcast your participation in any way, if you want to go on Twitter or anything like that, that's fine. Please just be respectful of those around you. If you want to take photographs or anything, just give people the opportunity to opt in or out, if that's okay. And that's really all the basic rules that I would like to ask that we work with today. So that's really my introduction. What we would like to do, if it's okay, is there's a short animation which gives a kind of introduction to the issues paper. I know that some of you may have read the issues paper in advance, some of you have looked at it now, but just to give the kind of key points of that, we'll show this short animation and just walk through that. And then I'm going to ask Andrew from the CCG just to give a perspective on the kind of local issues and on his perspective on it. So this will be the only section from the front.
When you're sick, you need to have access to the highest quality care available at any time of day or night, on any day of the week, and as close to your home as possible. The Improving Healthcare Together 2020 to 2030 programme brings together health and care organisations in Surrey Downs, Sutton and Merton. Together as local clinicians, we've developed a vision about how healthcare needs to be delivered in the 2020s and beyond. To deliver this vision, we need to resolve some long-standing healthcare challenges in our local areas, which will enable us to provide the very best quality care and outcomes for patients. So what are our challenges? 1. We need to have enough senior doctors to deliver care to patients and meet clinical standards. 2. We need to have buildings that are designed to deliver 21st century healthcare to improve patients' experiences and outcomes. 3. And we need to make sure your local NHS is financially balanced. Most services do not need to change and will continue to be delivered from both Epsom and St Helier hospitals. These are known as district services and include urgent treatment, planned care, elderly care and rehabilitation, and antenatal and postnatal care. A small number of services, however, do need to change to ensure we can care for you when you're acutely unwell. These changes need to be made within what is known as major acute services. Major acute services cover A&E, acute medicine, intensive care, emergency surgery, paediatrics and complex births. We've looked at many ways we can meet these challenges and have created a series of tests which, if passed, would deliver our vision. These tests, which we've applied to many potential solutions, are 1. Does it maintain major acute services within the local area? 2. Does it help us meet our agreed clinical standards? 3. Is the site suitable to deliver major acute services? After applying these tests to identify which ideas would work best, we've come up with 3 potential solutions. These potential solutions would mean locating major acute services at either 1. Epsom Hospital, 2. St Helier Hospital, or 3. Sutton Hospital. District services would continue to be delivered at both Epsom and St Helier hospitals under each solution. Now, we want to hear your thoughts on the challenges, these potential solutions, and about what's important to you. As we're at an early stage in the development of our thinking, your thoughts will help shape our ideas. We're open to hear all other potential solutions and will consider all feedback. You can find more information on our website, where you can download a copy of our issues paper that goes into more detail on the challenges we face and how we propose to address them. The website also gives you a number of ways that you can get in touch with us to share your thoughts. Visit www.improvinghealthcaretogether.org.uk and follow us on social media for all the latest updates.
Okay, thanks Lisa. So I'm conscious there's quite a lot of information in there. It's the same information that's in the issues paper, but hopefully that, for those of you who haven't had a chance to look at it, gives you some of the headlines. What I'd like to do is ask Andrew from the local CCG just to give his perspective on it. Sorry? Oh, okay. So Andrew, I'll hand over to you briefly and to give your views.
Thank you very much. Good evening everybody. I'm Dr. Andrew Murray. I'm a GP in Merton and I'm also the chair of NHS Merton Clinical Commissioning Group. So we're the organisation that's responsible for buying, planning and monitoring health services for people who are registered with GPs in Merton. And we're one of the 3 CCGs who are involved in this process. So there is ourselves, the Sutton CCG and the Surrey Downs CCG. So those are the CCGs, clinical commissioning groups, that are responsible for the majority of patients that currently access services from Epsom and St Helier hospitals. As you know, Epsom and St Helier NHS Hospitals Trust did some work last year as they were thinking about how did they preserve their future, what did they need to do to really deal with some of the difficult issues they were facing. And they really focused in on three main issues. The first one, this is all in the brochures, but just to summarise, the first issue was the one of workforce. So the fact that they don't have the right number of consultants to continue to run what we would consider to be the best standard of services across two sites. And that's really important. That relates to the clinical standards that we've agreed we really need to be meeting in all our hospitals in South West London. The second issue is the one of estates. So the quality of and state of the buildings on the St Helier site are poor, and we desperately need to do something about that. And Epsom also needs some significant work. So that was the second issue. The third issue is the one of finance. So looking at the cost of continuing to operate a full range of services across both sites. So those are the key issues that they have identified. Obviously, as part of their work, they've come up with the three options that you've seen. We're also considering the fourth option, which is keep services as they are. The information we have today says that isn't a viable option, but we are going to test that fully. What I need to be clear about is obviously the Trust did their own work to look at the issues for them and what they felt needed to be done to preserve their future services and to create a viable future for the Trust. Now, as commissioners, we have to run our own process to look at the work that the Trust have done, to look at the issues they've identified, to look at the options they've identified, and to really test those. And we are running an independent process to do that. We really don't know what the right solution is. What you've seen presented here is our current thinking. That can change, and it may well change. We are doing a lot of work at the moment, so this is early stages of engagement and it's early stages of the process. So at the moment we are looking at a number of things. We're testing the assumptions they've made about workforce. So they've looked at the numbers of consultants and how easy it is to recruit and retain consultants across two sites. We're testing that. We're also going to be looking at middle grades, not just consultants. We are looking at the specific impact of any changes on deprived communities. We're looking at the impact of any changes on other hospitals in South West London. We're looking at issues such as travel times. And this work is all going on and it has not concluded. But when it does, we will report on that. We will publish any relevant documents. And we will continue to engage through this process. And we'll be coming out and having a number of further engagement events and sharing our thinking as it develops. This is a separate engagement exercise from the one that the Trust ran last year. This is what we call in the NHS engagement, which means we're listening. We don't have formal proposals that we need you to vote on, but we want to hear your views. If it gets to the point where we have agreed how we're going to make a decision and we come up with a decision where we think there's a preferred option, we will then need to enter a process of formal consultation, which is a legally prescribed process which we need to go through, and we're not near to doing that at the moment. So I hope that just helps summarise where we're at and what our current thinking is.
Thank you, Andrew. I don't know if James and or Ruth from the Hospital Trust, if there are a couple of words that you wanted to say, just reflecting on that.
Thank you. Hello everyone. My name is James Marsh. I'm a renal physician, largely based at the St Helier Hospital, but I work across both sites, and Ruth sitting at the back is a paediatrician, largely based at Epsom, but working across both sites. We're the two medical directors, sorry, you've got sun in your eyes. We're the two medical directors at the Trust. I just wanted to reinforce the message as a clinician about some of the challenges that we face day to day, delivering the best quality care for the population of Epsom and St Helier. We we're working in buildings that are not designed for modern healthcare, and it's absolutely clear that whatever the solution is, we need to upgrade the quality of the buildings that we work in. Secondly, we do not have enough doctors to provide the most modern, up-to-date, responsive healthcare on both sides. And we use a huge amount of effort and a huge amount of money looking for temporary agency doctors to backfill all of the vacancies. And that's not a very efficient or effective or high quality way of delivering the healthcare that you deserve. So whatever solution we come with, we need to think about how can we design healthcare that is responsive to your needs and will be fit for delivering healthcare for the next 30, 40, 50 years across the whole of the population that we serve. We're here to listen to you and to answer any questions that you might have as a clinician. We'll start off on one of the tables, but I know there are a lot of you here, so we may move from table to table if that's helpful, if there are particular questions that we can help you with. So I think that's all I want to say.
Thank you, James. Okay, and as James said, I'm conscious that we have quite a lot of people, so I will move our clinicians around so that you all have the chance to speak to all of them. What we would like to do, if it's okay, is to have an initial discussion at your table just about the content of what's been said. You may.
To the best of my knowledge, I have never met James, but I would say to you, James, how do you expect us to believe that this is a blank piece of paper when the Trust, in its engagement, didn't deliver letters to anybody from Mitcham and Morden who lives in this room, but delivered them to the areas around Epsom and the areas around Sutton? Nobody asked us. The video that was showed talks about nothing much is going to change if you lose your A&E and your maternity. That's ridiculous. You simply will not have a real hospital there anymore. You'll have some sort of day facility plus. Isn't it important to be straightforward and honest with people? This is my 20th year of fighting consultation after engagement after consultation about the future of the St Helier Hospital, and I would very much like to hear somebody from the Trust or somebody from the CCG talk about how no, the engagement the Trust did wasn't good enough. And yes, you do have to consider it. Where do the people who are most ill live? Where do the people who don't have access to cars? How do people who require public transport use the services that are going to be provided? And I just think it's important to have some sort of balance, because there is an agenda here, and we know that that agenda is to put those facilities on the Sutton Hospital site.
What I'd like to do, if it's okay, to make sure that we address all of these points, is I'm asking Matt, who is up on the stage, just to capture some notes as we go through. And I, rather than go straight into the queue, I'm going to collect points and then ask the Trust and the CCG to address them. Okay, so we'll try and capture these points as we can. Yeah, we'll do it on the screen so you can tell us if we've got it wrong. So that's the previous engagement. Okay. Steve, I think you can sort of say something. Could I ask people just, I'm going to assume everybody knows who you are, but would you mind introducing yourselves?
Thank you. I'm Councillor Stephen Alabritis, Councillor in Ravensbury Ward. You're in my ward here, so thank you very much for coming to Ravensbury Ward. And also leader of the Council of the London Borough of Merton since 2010. My concern is about minds made up. So we've had the presentation. It says there are three options. One is St Helier, the other one is Epsom, and the other one is Sutton. Then it goes on to say that your district services will continue to be available at Epsom and at St Helier. And that, to me, logically seems to say to me, well, the main hospital will be therefore at Sutton. And the emphasis on the state and the standard and the buildings, and the fact that clinicians are not happy or won't be able to work to their best in either Epsom or certainly in St Helens. Everyone keeps talking about the bad state of that building. Again, that lends itself to Epsom. So I just want to see these kinds of statements toned down so that we do get the confidence and the trust that this is a truly open-minded engagement by the CCG. I don't think the CCG will be as bad or as minded as the trust, but we do expect the CCG to do a genuine independent, and I was pleased that there will be an analysis on deprivation, on where people come from, on transport and on equality assessments. I think that is crucial and very important, something that was missing from the engagement. Thank you.
Thank you, Stephen. Okay, so I think there were some questions in there. One was about the previous engagement by the Trust and the issues with that which people have identified. There was a question about the CCG, which really is just say something about to what extent this is a process where all three options are open. And I think there was a third point which both of you mentioned, which was about deprivation, access to healthcare, and I think the CCG may be able to say something about at least how they're assessing that. Okay, I'm going to ask Andrew if you want to. Oh, you first got one.
I'm not going to comment on the first one really because it's not my place to, but the CCGs have certainly not already made a decision to choose Sutton. We genuinely are looking openly at the issues and we want to do the work and come to the conclusion about what's the best solution for people in Merton and people in Sutton and Surrey Downs, because we have to consider the whole area, but as the Merton CCG we're particularly concerned about the needs of people in Merton. We are doing those analyses. Probably the best person to comment on those is Andrew, who's running the process. Do you want to say something about the impact analysis?
We're just going to make sure that everybody has microphones so you can hear, and we'll do a second round, if I may, we'll do a second round of questions once we've addressed these, and we'll make sure that we come to you two gentlemen who had your hands up.
So just a few things. So my name's Andrew Dimitrais, I'm the Programme Director, and I work for three CCGs, Sutton and Surrey Downs. So there were a few, I think, important questions. Can I just reiterate that I'm responsible for making sure that all the CCGs follow the right process? There is, I think, as I said at the last discussion event that we held in Merton, that the process that CCGs follow when they're considering any substantial variation or significant change is quite prescribed. There's a process that we have to follow. We have to effectively make a case to our regulators, and that's principally NHS England. So all the outputs of the work that we will be seeking to do over the next few months will have to be considered and put forward in what's called a pre-consultation business case. We'll have to make sure that that pre-consultation business case is accepted by not just the governing bodies, but by the regulators, and only then would we consider going to consultation. We may come up with a preferred option or a solution, and if that's clear from the work that we do, then of course we'll make that absolutely clear, I think, in that document. I'm not going to specifically comment on the district services, but I'm going to ask Ruth just to give a comment on that. But there are some important bits of work that will feature, I think, as we go forward. Travel and transport is a really important piece, as the leader made quite clear. And we've engaged a company called Mott MacDonald. They do a lot of this work nationally to do a baseline analysis of current travel times between the three hospital sites. And of course, the thing that I think people are most interested in is what would be the impact of those site-based options, whether that would see the location of major acute services of Epsom, St Helier, or indeed Sutton on travel times for people, and whether or not that would have an adverse impact. And of course, depending on who you talk to in each locality, whether you talk to the population in Epsom or in Sutton or in Merton, they're all very, very concerned about what that might mean and whether or not, if you're an emergency or you have a planned episode of care, whether you're still able to get to hospital in a timely way. And of course, we will have to look at whatever the options might be going forward about whether there are things that could be put in place to mitigate some of those impacts. And we will very much be guided by the advice and input that we get from the public, as well as other stakeholders who have been considering those. What we have to publish at the end of this whole process is what's called an integrated impact assessment. So we have to consider travel, transport, as Andrew has said, the impact on deprived communities. We've also got to look at the health needs of each of the local populations, so we have to do a more thorough piece of work looking at the health profile. Each CCG is very, very different in terms of its population. And then all of those inputs need to be considered alongside what it would cost to invest in any new facilities, and whether or not we're able to secure the money nationally. And as I've said before, and I know others have said, we will not go to consultation unless it's clear that we have the prospect of securing investment. And that is a cast iron commitment that the governing bodies have made going forward. So I think there's a lot more work that we've got to do. We are treating it really seriously. We haven't made up our minds, and it will be important that the governing bodies really treat this absolutely as seriously as I know all the population are, before they're able to come to any further view about the future.
Okay, thanks Andrew. So that was a bit more about the process that the CCGs are looking to talk about, and you also talked a little bit about the assessment process for things like travel and deprivation.
So let me just pick up the district hospital thing that Stephen mentioned, district hospital services on, because we say in the document there will be district hospital services on the Epsom site and the St Helier site. So let's just clarify, if, for example, St Helier was the major acute site, you would have both major acute services and the district hospital services on the St Helier site. And actually I think the district hospital model that's being described is really good. And I think it could be a real enhancement. So there's more in there about rehabilitation, getting people out of hospital in a really good position to go home, and being able to see people before they're at the point of needing to go into a major acute part of a site. So essentially you'd have the site split into a major acute part and a district hospital part. You'd have those both things running in parallel.
Okay. So that was just to clarify that in each of the three options, Epsom and St Helier retain their district services in each option. Yes.
Correct. In all three of the options, Epsom and St Helier retain their district hospital services. In fact, not only do they retain them, but we're looking at an enhanced model of district hospital services.
Okay, so that's what's been forward. Okay, what I'd like to do, if I could just collect some questions, I'm going to ask Redco if you could retrieve my microphone, please, and. So the first question, which was the trust on the lack of engagement that was received last time. So James, if you want to touch on that, and then I do want to come to your questions there. Siobhan,
we met this time last year. You kindly facilitated a meeting at Morden Park Baptist Church.
Oh yeah, because it's July, August. There's got to be time for an NHS consultation on the future of St Helier.
So that meeting was very well attended, and I just want to reassure people that we are not yet at the process of a consultation. Consultation is a huge undertaking that requires much. It does require a lot of money. We're at the engagement phase, and we wouldn't get to a formal consultation phase unless there was a realistic prospect of having an answer that would produce a substantial change. So I absolutely agree that if, as and when we get to a consultation phase, the communication is really, really crucial, and that we make sure that as many people as possible get the opportunity to participate.
So there's a specific question which was around the consultation, the engagement, which was done by the trust previously. James, I don't know if you were involved in that engagement work particularly, and if that is something that you're able to comment on.
I think I can to a limited degree. The work that was done last summer was an engagement. It wasn't a formal consultation. We did not mail shot the whole of the catchment population. Our catchment population is almost 500,000. So to send a letter to everyone in that catchment population would be extremely expensive. What we did do is ask members of the trust who work in the trust if they were willing to deliver leaflets, 100 or 200 leaflets, around their locality about where they live. So we didn't discriminate actively against any catchment area. It was just based on where our staff work and where they volunteered to deliver leaflets locally to their own homes.
Okay, so I think that's what James has told us, is that that's the process the trust went through last time. I think it's very clear that the perception of many people in the room is that that process is not what you would like to see followed in future. And so
we are capturing the answers to the questions.
yes, so Shelley's noting the answers as well.
Questions, and we've got our facilitators capturing everything else that's being said.
Okay. Thank you. So that's the word flawed. So I do want to give, I know that people have been waiting patiently to ask questions. I think James has given a response on what the trust did last time. I think Andrew might just want to touch on what the CCG might do themselves. But I do, please Andrew, if you could keep it brief, I would like to get to the questions from people who have been waiting.
Sure, so I'll be really, really brief. That if we get to a place that is considering consultation, that we will make a commitment to make sure that every household gets an appropriate communication regarding the material that we then seek to consult upon. We can do that through leaflets, we can do that through whatever, but there is an absolute commitment from the CCG that we will address any issues by getting appropriate coverage across the 3 CCGs, and we will make that happen.
Okay. Thank you, Andrew. Okay, I'm going to go to this gentleman here who's been waiting patiently. If it's okay, I'll try and capture a few points because I think it'll be quicker to get them to address a few at once. Okay?
Yeah, thank you. My name is James Whiting. I'm a resident in Mitcham and a service user. I just wanted to ask, and if this is the right time and place to do it, well, it's because I'm looking at the issues paper and I'm not an NHS management consultant or staffing expert, but I'm looking at the table on page 15, and it seems to me a bit of an odd table because one of the priorities is about recruiting doctors, but actually if you look at the abstractions there, they're going to reduce the number of obstetricians considerably down to 12 to 16. And somebody needs to explain to me, because I don't understand what the site issue is about. I sadly, have to go to consultants sometimes, and my appointments are often moved and delayed. And it's not to do with the site where that person happens to be. It's to do with the number of, the capacity of that consultant to be able to deliver services to us. It doesn't really matter where, well, it does matter in terms of transport, but in terms of getting the appointment, the site is irrelevant. And what this shows is actually you are reducing considerably the services that are available by going down to on-site acute hospital. And surely with the growing population and the pressures in the surrounding area, that that is not a credible solution. That is not going to make an improvement in our health service in this area. It's going to make it worse.
Okay.
It's there in bread and butter.
Thank you. So that's the point about why in a one-site solution there are fewer staff and how that works as an improvement to capacity. I'd like to go to the gentleman behind who's been waiting patiently, and I'm going to work my way round. So we will come round.
I'm trying to orientate myself in this consultation because if you have a discussion about solving a problem, the sensible thing to do is to first define the problem. Now, all of the documents that I've read rush through the problem, rush through the general discussion that follows that, and rushes to a conclusion which says that this or that hospital is going to lose its acute service, its A&E, its maternity services, and so on. Now, I haven't heard yet the nature of the problem described in sensible terms. If we don't have enough doctors, then we need to get more doctors. The idea is you don't create more doctors by closing down one of the major parts of a hospital. What you do, of course, is reduce the capacity of the NHS to deal with the health of the residents, of which I'm one, in that particular area. So if we're going to deal with the discussion of an answer, then for goodness sake, someone start telling us why the obvious solution to the problem, which is recruiting more doctors, is not actually being the one that is being discussed.
Okay. Thank you. So that's an issue about just not understanding why this issue about not having enough doctors isn't being addressed. It is being addressed through the options that it is.
Well, it's a broader problem than that. It's the problem of defining the problem before you rush to a solution.
I will take that. Okay, I'm going to work round. We'll come back to you, sir. So there was a gentleman at this table who's been waiting.
Thank you very much. I'm Owen, I'm a councillor in the neighbouring ward. And I want to build on the points made by John and James rather to do with the methodology. What I'm slightly concerned about is the way that they've just jumped from the long list to the short list, specifically through clinical test 2, as it's called here, which is workforce delivery. I don't understand how that was made. When I look at the map on, which is really rather rubbish map, on page 4, it doesn't hold in anything such as Vaughan and Stephen brought out, which is actual need. And the obvious thing, if 3 doesn't work, it's too expensive, people can't be recruited, is that you look at 2. Yet, we've jumped all the way to only having 1 acute service, and there isn't an explanation of why that was done in clinical step 2. I think that needs to be explored, and I think the option of having 2 acute service hospitals rather than 1 needs to be reintroduced.
Okay. Thank you. So there's a couple of points there which we've got. One which is around the long list, the short list, and then the other which is about why we're looking at 1 rather than 2 options. Okay, we're going to keep going around and get a couple more, and then we'll try and address them together.
Thank you. I'm Councillor McCabe. I represent Ravensbury Ward along with Stephen and Natasha, and have done for 32 years. I've just been re-elected for the 9th time, and I think I know the people that I represent. This is the ward that's closest, along with St Helier, to St Helier Hospital, and there are a whole range of issues that I think need to be. Firstly, trust. It is a hospital trust, and there is a lack of trust amongst local residents because on so many occasions, people from the NHS, and there are different faces every time it happens, have come down and consulted with us about taking away a hospital that's been here for a very long time. I think this whole thing is finance driven, and it's disguised as an attempt to improve standards. But some of my colleagues have already mentioned the fact that there is going to be a reduction in beds, and it doesn't improve standards if you have people having to go miles from home to hospitals that are already bursting at the seams, and it really doesn't hold any water when you put proposals up like that. You talk about your workforce problems, and I employ people. If you are constantly talking about the future of some place of employment and it's always under threat, then is it any surprise that you have problems recruiting staff? You talk about the estates in a hospital that has been starved of resources, and even when money has been made available by the government in the past to improve the standard of the estate, that hasn't happened. Why hasn't that happened? We've got an ageing population. The people I represent, many of them are elderly. Many of them rely on public transport. And yet the bit about deprivation and looking at transport seems to become almost an afterthought. That should be the first thing that you're doing. That should be in this document, not something you're going to produce at some time in the future. And that suggests to me that your priorities are different to mine. So for all those reasons, I'd like to say very clearly, the people that I represent want to keep St Helier Hospital. We've been told when we had the debate about Brexit that that nice man Boris Johnson was going around in his big bus and there would be £350 million a week available for the NHS. So put some of that into building a decent hospital and recognise that people don't want you to close hospitals because they actually, with the ageing population, need more hospitals. And I also want to know what the number of beds will be under this proposal, and how does that compare with the current number of beds, and how does that compare with the European average?
Okay. So there's a whole list of specific issues there, some of which are about numbers of beds and how those compare with averages. There was a point that you started with, which I thought was important, which was around trust, which I'd like to ask somebody to address. And I think it was two points that we picked up from others as well, which one was about the deprivation and travel analysis, and the other was about this issue of if we're reducing sites, how is that improving care? I'm conscious that I have noted that we've got a set of hands. What I would like to do is ask Andrew if you want to tick very quickly through a couple of those questions where you're able to clarify those, and then I would like to hear from everybody else. What I would like to say is I would like to make sure there's as many of you as possible who have time to speak, so I'll ask you, please, if you can be brief. And that goes for you as well, Andrew.
So
that will help us.
I'll be really brief, but I know that Ruth wants to answer, I think, a couple of the questions around workforce, because I think they are really, really important, but just let me have a go at a couple. So, numbers of beds. We are clear that we have to ensure that there's the right beds going forward, and that that's sufficient to meet both the future population needs in terms of rising demand, but also that we don't have less beds in the future in order to deliver care. That doesn't mean that the type of beds that need to be available both on the district hospital site as well as the major acute site might need to change. We don't know at the moment because we haven't concluded the work around the clinical model, what that will look like, but there is a very clear test that NHS England will want us to pass, and we want to pass it, which is that there are not less beds available in the system going forward. We'll publish all of that work when we've completed that work, and we have to do that with primary care clinicians and the hospital trust. Deprivation is not an afterthought, and the reason why it's really important, and the reason why we asked a separate body to look at this issue, is that we don't necessarily have the expertise as CCGs to do all of that work, although we want to work closely with the local authority to understand what the impact of any change would be. As soon as that report has been made available and the work's been concluded, we'll publish it, and it'll be one of the important bits of information that will feed into the process. But I just don't have that report available at the moment, and once it's concluded, we'll make it available and we'll debate it in whatever form that is necessary. Just a quick thing on the long list to short list. Those are the tests that we've used that the governing bodies thought were the most important. There isn't one at this stage around money, despite the fact that I know there's some very strongly held views that that's the most important thing. Of course, anything that we propose going forward will have to be affordable, and that represents a real challenge. And what the tests are that we described in the book are only to get us to a provisional list of options. We will have to do a full option evaluation, and we'd like to involve not just clinicians and managers in that, but also, I think, others from each of the CCGs to help us evaluate the options. And we need to think through how best to do that, I think, going forward. On the doctors, Ruth's going to say something.
Yes, thank you. So we'll touch on workforce and then we'll start with Fran.
I'll try and do this briefly, because I think the first question was around the table on page 15, and I'm very appreciative of the question and the challenge, because actually I think moving forward we could present the information that we've got and the gaps that we've got in a clearer way. So the services that we've defined there are what we're calling the 6 core services. They are the services that a hospital, an acute hospital, has to run 24/7. So we're actually not talking about outpatient services in the context of these. What we're talking about are the number of consultants that you need to have a consultant-delivered service 24 hours a day, because we know that there are strong links between the seniority of the doctors delivering your care and the clinical outcomes. So, if I use the example which was cited around emergency department, what that table's saying to you is at the moment we have got a total of 14 A&E consultants who are providing a service between them for 2 acute hospitals. The standards say that the number you should have to run that level of service is 24. There is therefore a gap of 10 consultants at present. Now, to go back to the challenge around, well, why don't you go out and get more consultants? I think it's very important to stress that as a trust, we actually have a very good track record of recruiting consultants. We do not struggle to recruit consultants. The challenge is, though, that nationally, the numbers of consultants who are being trained is determined not by us, but is determined centrally. And there are not enough consultants trained and available nationally for us to go out and recruit 24 consultants. That is the issue, that is the challenge, rather than it being about either money or about attractiveness of the trust.
Okay, so from your perspective, Ruth, that's the issue about recruitment, it's just about availability. Okay, if I may, I would like to hear from some of those who've been waiting and we haven't heard from, if I may.
I mean, that says we're going to end up with fewer doctors.
Sorry, sir. So I think Ruth was talking to the point about, which you raised actually, I think, which was about how do we recruit.
That's why I'm continuing.
Which was why don't we recruit more doctors? And Ruth has given the trust perspective on why they're not recruiting more doctors. The separate point, I think, was...
I'm sorry, it just wasn't addressed. The leaping from 3 acute hospitals to various options of 1, without looking at 2 and explaining it, was not addressed.
Thank you.
The methodology and all the assumptions and facts you didn't know, right? Just raise the question as to why you've done this methodology now before knowing those things. You're all bright people, academics. You know that if this was a piece of academic research, it'd be thrown out the door. Yet you're doing it, and you're going to affect 250,000 people's lives on the back of substandard research where you haven't got a decent methodology. It's just wrong.
Thank you, sir. So Ruth, I think if I'm correct, you were talking about recruiting consultants. I don't think you were talking about the model of having 1 site and how many doctors you would need versus 2 sites. Which I think was...
I was talking about the quality of the healthcare, and yeah, okay, I accept your point about it's not outpatient. So, the doctors in themselves, when they deliver so much as one person, I can see there may be some efficiency in working together on one side, but this doesn't add up. I mean, you've got here 26 obstetrics, now you're reducing that, you're actually sucking them. You're sucking them and reducing it to 12 to 16.
Yeah, so I think several of you have raised this issue, which is, does this in fact result in having fewer consultants? And I think James, do you want me to pass it to James?
Because you want to give us the facts about the second hospital, because you did so briefly the facts. There are clearly doctors on the second hospital that won't have key services that you've not told us about. I assume they won't be able to look at the hospital that aren't here. So once again, your information is very sketchy.
Okay.
You can't expect them not to be upset because of sketchy information.
No, and I think that we're trying to address it as well we can briefly.
So I think to be absolutely clear, the table here, where it says current consultant staffing, what the table lists are the number of consultants currently employed who work across Epsom and Surrey. That is the total number of consultants employed in those specialties. So to take the example of obstetrics, I completely agree. We have a good number of consultant obstetricians because we were able to recruit. They had been trained in obstetrics, and so we are currently able to provide the requisite 24/7 consultant presence at both Epsom and St Helier, where our consultants deliver 24 hours a day. There's a consultant delivered stroke-led service. We cannot do that currently for A&E and acute medicine because we don't have enough people.
Okay, so I think that's speaking to the difference between those different services, and that in that table it's telling you different things. I would like to hear from some of those who've been waiting really patiently and who haven't been able to speak. If I can come to the front, because I haven't taken questions from these 2 tables yet, and I am going to work around. Yes, I appreciate it. Okay, so we'll do this. Okay. Would you like to go after this lady? Thank you. So we'll go to this lady here, and we will work our way around. We
Sorry to say that I'm not invisible. I am absolutely, totally disgusted with this so-called event. You are treating us like we're idiots. We are not idiots. No proper information. You're not telling us what we want to hear because you've already made up your mind. I'm a local councillor. I represent people in Mitcham. They are absolutely worried about all this. Some of them use St Heliers. If you go to St George's. Now, if we don't have St Helier as a hospital, all the patients, all the people are going to be shifted to St George's. Now, St George's is full and cracking at the brim. This is absolutely ridiculous. You can't come to us and pretend that, you can either have Epsom Hospital, you can have Sutton or St Helier, when you've already made up your mind. All the language you're using does not say that you actually want to build a new hospital in St Helier. The government, the Labour Party government, put some money away for St Helier for a new hospital to be built. Where is that money? The government took it. Why don't you try and get the money and put it back and build St Heliers again? Instead of messing us around, telling us all these stories, all these nonsensical stories you're giving us. This is wrong. We're adults, we're not children, we're not stupid. Come and tell us the truth. Don't come and lie to us and tell us fairy stories. It's ridiculous. I've come all this way out of my house to listen to a whole lot of rubbish.
Get the impression that you don't want a specific response to that. So we're going to move on and ask if we can hear from this lady here, and then we'll work our way around.
Hi, I'm Natasha Ryan, I'm a councillor for Ravenbury Ward, again, a ward that will be severely affected by any change in services in Helier. Just to the point on staff recruitment and retention, are doctors not attracted to things like A&E, intensive care, and difficult births, because that's where you get your training? You remove that from the hospital, suddenly it becomes not worth your while to go there. And then secondly, on the point of the estate and how it looks and what it needs, no one is saying that maybe that does need some help there, but how much have we spent having this conversation over and over again? And how many times could we have refurbished that hospital if we had taken that money and invested it when we should have done? I think we need to have
Thank you, Natasha. I appreciate the waiting. Okay, if I can ask, but this man here who did put his hand up very early, and then I'm going to come to your table, guys. Bear with me, we'll get around as quick as we can.
I just said 2 things. You've not been honest with us about the pressures on you, and I appreciate the pressure, that the South West London CCG plan, the 5-year plan, says that South West London is to save £838 million in 5 years' time. This is the plan, it's open, so you've got to cut back. You've been honest about it. It's the government's austerity plan. Absolutely. That's honest. They need to be honest about it. And I think we have actually done that. Second thing, that you have not learned the lessons from other parts of the country. Other parts of the country, for example, on the North Tyneside, acute services with 3 hospitals were shut down, a new acute hospital opened, and what do we get? We got empty ambulance clinic. We have patients in the corridors. Once this is true, it was complete. It was a total failure. It's failure. So if you're going to reduce 2 acute centers to 1, you're going to get ambulance queuing in the corridors. I predict that, and we haven't looked at it. Thank you.
Okay, thank you. So I think that first point, Matt, was about the STP, which is the larger plan for South West London. Okay. All right, this table, thank you. We'll work our way around this table now.
Thank you very much. I am actually a nurse, and I trained in 1967. Some of you weren't born yet. And I have seen all of this 100 times over. What you're not doing is explaining what you mean by district hospitals, what you mean by acute hospital, to people who might not understand what you're talking about. I worked in Croydon for many years, and Queen's Hospital went to district. So as Croydon, where are they now? They're no longer in existence. We are talking about the slippery slope when you start talking about district hospitals. And you're not mentioning ours. Are the district hospitals going to be 9 to 5 and then become a graveyard? You need to explain yourself properly to all of us. And as my colleague said, we are not idiots. And I have spent all those years in the health service, including lecturing, so I'm not stupid. Please tell us the truth.
Thank you. So that's, I think a couple of points there. I'm just letting Matt catch up to make sure we've got all of this. Okay.
Cool. I just want to go to the point around trust. I think it's clear from everybody in this room here that the NHS has a lot of work to do to gain the trust of residents, particularly in Mitcham, whether that's the CCGs or whether that's the trust in Epsom and St Helier. I think the NHS Merton CCG has a responsibility to fight our corner in this battle. Residents of Mitcham need to have a voice, and it needs to be loud and clear. And I think the voice, the opinion in this room is loud and clear in what we actually want. I think the CCG, in terms of engagement in the past, has been awful. When I take into account the Wilson Hospital site, where at least 1,000 patients were left without a GP when they closed the walk-in centre. And where did we go when the walk-in centre closed? We went to A&E, increasing demand in those vital services. So I think the CCG really needs to step up to the plate, fight for Merton, and I think there needs to be a commitment tonight from the chair of the CCG to actually tell us what he thinks a successful consultation will look like in terms of percentage of responses from people in Mitcham, because I want all of the people in Mitcham to have their views fairly represented. So if you can't get over 50, 60%, whatever you think is a success from people from Mitcham, then I think you've failed in your job, and we need to hold you to account. So we need to know what you think is a successful response rate from people in Mitcham.
Thank you. Okay, I'm going to continue taking points and working my way around. One of the things I would say is I would like to have some time at the end of this session to get your views, to get all of your views about how the CCGs can start building back that trust and what that future consultation needs to look like. That's one of the most useful things I think that we can get out of this session for us as the CCGs, is your recommendations about how to do that. I won't try and do that at the end. Was your hand up, Mother? Yes, it was. Okay, so let's go here, and then I'm going to work my way around, and we'll do another lap.
Thank you. I'm Sally Kenny, a councillor for Lower Morden, and most residents use St Helier Hospital and I've had outstanding care for my daughter who has been very ill, so I can only sing its praises. But on this issue, I think we're going round and round in circles. I've been with Siobhan campaigning perhaps for only 10 years, but it seems like a lot longer, and I really do not think we move forward at all. We are back with exactly the same propositions as we've had before. There might be some detail that's a bit different, but it doesn't seem to be moving us on. And I'm getting a bit fed up with the phrase going forward, because I don't think we are. I think we're stagnated. And I'm very concerned that coming across to me with everything that's coming up is the wish of the National Health Service and the trusts to provide adequate provision for the poorer population and the ageing population who have a greater need on the call of the national health. And it does seem, as the provision coming forward, although people deny the want to have it on the Sutton site with the Royal Marsden and the new Science Specialist Secondary School, it does seem to be that the way it's leading. And this is an awful thing to say. I am anti-euthanasia, but I actually think the way this seems to be going and neglecting the residents in the greatest deprivation in the area is going to have an adverse effect on their health and lead to more deaths. And I actually think, is this some sort of hidden programme? And I think we are neglecting needy people. And Merton is densely populated. Lower Moor is densely populated with elderly people and people with health cares. And I am very, very worried how our national health is going. And it was the pride of the world, the pride of Britain, the envy of the world, and we're losing it. And I think the care of people is not there.
Okay, thank you. I've got 3 points here, and then I'm going to do that back row that we haven't got to yet.
Sorry, can we have some answers? Because there's a lot of questions.
I'm very conscious, yes, that I want to make sure that we can hear everybody. Okay, is everybody okay if we take answers to those questions at this point? Alright, I've given this man the microphone. I'm not sure I can wrest it from him. So let me take his question, and then we will get the CCG and the Trust to address what they can. And I will try and make sure we get time to go to the others.
Can I just say, my name's Martin Welton, I'm a councillor in Pollard's Hill, been a councillor in Merton for 16 years, sat through numerous consultations. I have to say, this just feels like a rigged consultation. Why is it taking place in August, in the middle of the holiday season? It's clearly quite deliberate, because they know that people are not around. If it hadn't been for the work of Siobhan McDonough, I suspect this would have been very poorly attended, given the number of people who were sent information about the consultation. Certainly no one in my area received information about this meeting, which I think is an absolute disgrace. But clearly it's rigged in favour of more affluent areas. We've got, in terms of poverty, deprivation, income, health outcomes, life expectancy, it's hugely different in terms of these Merton wards in Mitcham, compared to affluent areas in Epsom and Sutton. St Helier, St Helier was granted £400 million for rebuilding the A&E. That money was taken away. This is a predetermined outcome. They call it engagement. It's another word for consultation. It's a rigged consultation. Thank you.
Okay, thank you, sir. Okay. So what we'll do is we'll try to get. We're doing our best to capture all of these points, and I just would say that Shelley is diligently writing everything down as well, so Matt's got summaries, but we've got more detail. I'm looking at Andrew and Ruth, but I've also got James here. I wonder if we could pick, I think there are some things that have come up repeatedly. I think there's the issue about deprivation and inequality, which I think a number of you have raised, which I think is really important. Perhaps we could get just your views on that. I don't know if there's anything further you can say about that, Andrew. Do you want to stand up, Andrew? Is that okay?
No, I'm very happy. I've got nothing more to add really on the fact that we've commissioned a piece of work around deprivation. I think that it's vital and it's essential that we look at that as one of the important things. I will say that all three CCGs have pockets of deprivation, and all three CCGs I know have an interest, I think, in that work. But I absolutely acknowledge, I think, the differential within Merton and mentioned around a local population and its specific needs. So I absolutely recognise that. I take the point about having these events in August. I was keen that we start the conversation, but I know for many that's not a good time. I absolutely accept that, which is why we wanted to hold some further events in September. I also appreciate that holding these sorts of sessions, even with Siobhan's help to gather people and come to these events, that we're not going to reach everybody. And I've said that we'll address some of the issues about communication with households if we get to consultation. We're going to try and run some sort of shopping centre type information giving events in September, when hopefully people are back from their leave. I know that Health Watch are very, very keen to help to try and have some discussions with some of the hard to reach groups, and also I've asked Traverse as well to look at helping us run some specific discussions with some of those groups. This is an ongoing process. It just doesn't finish in September, but we're trying to begin that dialogue. Just around publicising these events, I think I said this last time, we did only publicise them through the local guardians. I accept that not everybody gets the local guardian, and we did distribute flyers to GP surgeries, to pharmacists and so on. So in the future, if there are better ways that we can reach people or advertise differently, can people let me know, drop me an email?
Can you just give them out to the patients?
So I can't personally do that.
No, but that could be arranged, couldn't it?
Of course, and that might be the sort of thing that we need to do. Sure, I accept that, and I'm acknowledging that there are limitations. So if there are different ways that we can do it, then of course we will do our best to meet that demand. So those are the only things I wanted to comment on directly, if that's okay.
Okay, thanks, Andrew. So there is one other issue that I would quite like to ask. Andrew, you look like you were about to leap up. I wondered if you wanted to say something, Andrew, from the perspective of Merton CCG, about this question that I think has come up several times, which is about how do we start to build trust in the CCGs and in this process when it sort of happens several times. It's a really difficult. I appreciate I'm asking you a difficult question, and I'm perhaps asking you to reflect on it as a local GP as much as the chair of the CCG.
Well, I think how do we get people to trust the NHS or individuals working within the NHS is a difficult question. I'm not sure I can give you a satisfactory answer to that. All I can say is our role, in the roles we play, I guess we're taking our responsibility very seriously. So as a CCG, it is our job to represent the interests of people in Merton. We're taking that very seriously. You talk about how people already come up with their own conclusions. I think as the Trust have done the work on this, it's quite conceivable they've come up with views on what they think out of the different options would work better from their perspective. I think if you ask the different CCGs, they're probably looking at their own population, maybe come up with different conclusions about what might be their preferred option. Because I think we're unlikely to all come to the same conclusion given the information that we have at the moment, it's really important we come up with a really robust process where we look fairly at all the information. We set really clear criteria so we can make a fair decision when we balance all the different evidence. And I guess all I can commit to is that we will do everything we can to do that and to go through a fair process so that by the end of it, me and my board are absolutely confident that the decision that is reached is the right one for people in Merton and more broadly for all the people across the catchment area, and it is going to ensure a really good future for Epsom St Helier Trust and the services they can offer for local people. In terms of what does a good engagement or consultation look like, I don't think I can realistically give you a kind of percentage response rate threshold. All I can say is that for me a successful engagement would look like all the different communities in Merton have been reached, all the harder to reach groups we've been able to have conversations with. I think at this stage it's very early engagement. I think we've got a lot of questions. I think we've got a lot of work still ongoing. I think we're surfacing the issues. I don't think we're in a position to have some of the really detailed conversations we will need to have at later phases of engagement. And when we get to that, I think it's really important we go out and we meet with lots of different groups to do that properly. There's a slightly different answer to the question of what makes a successful consultation, because that is a formal process. Although it's not a referendum, there is a process we have to follow, and that will be much more strictly controlled. I hope that answers the question as well as I can.
I'm sorry, you're the chair of the CCG. You know, you're here to give us directions, to give us answers. Everybody here can appreciate what a good outcome and a good response would be. And I would say to you that if you only get 1,000 responses, I think you'd be very fortunate in an area like Merton, more than the current way that you actually engage with people. And I actually think that will mean that the whole consultation will be flawed, because you're not fairly getting the views of Merton and Merton. And you've not got any strategy from what you're saying at the moment that gives me confidence that you will do it. And you say you're trying to reach this harder to reach areas. So if you have a look in this room here, who is from the harder to reach areas? When you look at the population of people in Merton, how diverse we are. How have you done that tonight?
So,
I'm going to say, Andrew, that I think some of this you might not know the answers to. But I also would say that I wouldn't necessarily, that there might be other people in the room who are better able to talk about those specific events, for example. But I think there's a fair challenge there, which is about what does Andrew want.
Consultation to be led by NHS CCG as well as the other CCGs. They should know what a successful response rate should look like. You cannot go into these things and say, you've got no measure. You'll have measures for every response rate. I mean, companies that are high like yourself, consultants paid by taxpayers, paid by the NHS, you will know what your own measures are and what your targets are, because the NHS has set your targets with the number of people that you need to engage with.
So maybe what I will say is I think it's really difficult to give a concrete number. One of the questions we had that we wanted answers to tonight is, how do we successfully engage? So you're all here representing different areas of, well, a number of different wards in particular. So I think we would really like to have a conversation about what would successful engagement look like, how do we reach people in your constituencies, what do you want us to do? We've got a company running the engagement process for us, but we want your input. This is very early stages and we have the opportunity to shape it. So that would be a really helpful thing to have a conversation about from my perspective.
Okay, so
raise their hands tonight who actually was contacted by the CCG and got a letter through the door from the GP service that found out tonight.
I'm sorry, I'm on Twitter, but just to explain anything, what this meeting is about.
So there's a...
I can't see that being a success.
Okay, so I think, James, I think you want to say something about success. What I would like to... No. I mean, we could do.
I want to say something about Sutton and groups. So we are doing some outreach work with Sutton and groups. I don't have all the detail right to have today, but I will make sure that we get that out on the websites, and that we're very happy to share the detail of how we do it with anybody who would like that in the future. We just don't have that to hand, but we are doing that work, and it's specifically targeting communities we've identified in Merton.
Okay, so the one thing that I would, and I'm going to go back to taking questions because I would like to hear from those I haven't heard from yet. Yes, you can. If you 1 second. What I wanted to say is that one of the things I'll ask you to do today is to fill in an evaluation form about these events that tells us how you heard about them and how you'd like us to do them in future. I look forward very much to seeing your responses. So we'll capture that. James, from the trust perspective, I'm going to give you 2 minutes, and then I'm going to try and get people we haven't heard from.
I just wanted to give the perspective of what does it mean to work in the trust at the moment as a clinician, and why are we where we are? And I'm really picking up loud and clear the frustration that we've been through this process many times before, and the lack of certainty that we have. And as a clinician at the trust, I know our clinicians are very frustrated by the lack of certainty about the future direction of the clinical services that we provide. And what we want more than ever is absolute certainty so that we can plan properly for the future. Just to reiterate, the challenges day to day are that our buildings are not designed for modern healthcare. So we want to have buildings that are fit for purpose, and whatever solution is needed, we will need new purpose-built buildings. Secondly, we do not have enough doctors to deliver all of the acute care, and we particularly struggle because we duplicate the services at 2 sites. And we duplicate an A&E, medicine, but we have to try and recruit doctors to provide rotas at both sites, and that's what creates the shortage for us. When we had a conversation with the consultants of the trust, we have about 270 consultants, and 90% of them expressed the view that the right thing clinically is to try and consolidate our acute services on a single site, because that way the clinicians feel that we will be able to deliver safer, better quality care when you most need it for your very acute needs.
Okay. I very much respect your right, all of you to disagree. James has given his perspective on the issue. I would like to hear, if I may, from those I haven't heard from. I've got one more hand at the front. So if it's okay, I'm going to do the people I haven't heard from first and come back to you. So if I can do this gentleman here who's been waiting, and then to these 2 ladies, 3, 4 ladies, and the gentleman at the back. And I'm going to ask Lisa at the back if she can put the lights on.
They're coming. Put the lights on.
Thank you.
My worry is unintended consequences and knock-on effect of cutting services. Like, if you cut public health budgets, it actually causes more money to be spent at the end, and like a backfire effect, and that's not taken into account. So what you intend, often the opposite will happen, like downgrading intended or overwhelm other hospitals will lead to more waiting lists, health issues will get worse. Will mean people suffer. This will mean other hospitals are more likely to have difficulties, financial difficulties, more likely to close, and this will lead to the problem spreading like a virus to other neighbourhood hospitals. Cricket Green GP's practice now is so busy because Wilson Hospital walked in and GP's closed. And the other, my mum recently was really unwell, and we had to go to Wide Awake Clinic when we could have gone to Wilson Hospital, like she always does, and now it's giving her more anxiety, like, oh, we have to go further, and if anything goes wrong, like high blood pressure or whatever. And so I feel like people don't take in, I think this will lead to more money being spent in other ways that is unintended. So you have to look at all the consequences and not just the obvious, what's obvious on the surface.
Okay, thank you. Thank you for sharing that. Okay, I'm going to ask if you can run to the back now, and I'm going to take, there were 5 hands up here, and we'll see where we get to. If you just want to work across, we can start with this lady here, and then we'll lady at the back.
Hello, I'm the fabled someone who just lives in Mitcham. I'm here, but that's because someone from Epsom invited me, just saying. So I'm not a counsellor, I'm no one special, I have no knowledge in particular, but I'm just going to tell you, because you talked about trust, some of the words that I've heard tonight. I've heard deliver this vision. Deliver it means you're finding a way to put that, you're delivering it to us, it's not a consultation. Changes need to be made, making a case, business case. These are all words that have come out of mouths this evening. The word invest, well, when I hear invest, I think there must be profit to be made somewhere. You said you're looking how to mitigate impact. That is what worries me about asking the following questions, because I feel like you're finding out what our concerns are in order that you can get some interesting language across to kind of baffle us in the future with it. So I am going to ask my questions, but here we go. Sorry if they sound really ignorant, like I say, I'm not used to this. How can the same, or now maybe in the future, a greater number of people be served better by fewer doctors in one site further away? It just makes no sense at all. Okay, my second question is, you've said that we'll be left with these district hospital shells. If the buildings are currently not fit enough, how can those district hospital shells that we'll be left with, how will they be made fit enough if the money that would have gone into making them fit enough has now gone into some other new build somewhere else? It just doesn't financially stand up to reason. And where is the fourth option? Why is there only 3 options? Why is there an option of spending all this money on the places that we've got now? It's just obvious. There you go.
Thank you. Okay, all right, let's just work our way around this table. Thank you.
Hi, my name is Sue Portman. Some people know me in the here. As an aside, Sutton Hospital. The last time I went past Sutton Hospital, it was derelict, and it's earmarked to be a high school by London Borough of Sutton. So, where's the hospital going to be? That's just one side. I was born in St Helier Hospital 70 years ago, and I'm still using it today. And I feel really angry that you're having consultation after consultation, year after year, nothing ever gets done. Don't you think the people around here deserve a hospital that will serve them from the cradle to the grave when all of the life stops in between? Childbirth, serious illnesses, visiting relatives in the hospital with clean pyjamas, taking them fruit. If they're in Epsom, that's really hard for people who haven't got a car. Don't expect that we're all going to die or give up complaining. We're not going to. If you look around here, I'm one of the older people here. The younger people still want that hospital. So just get on with it, please.
Thank you. Okay. At this table, there were, I think, 3 hands on that table.
Yeah, I've been listening to all the discussions and I totally support what everyone's saying about the hospital. My issue is completely different, so I'm just interested in preventive care and public health, and I didn't see anything in the 2020 to 2030 plan which talks about new approaches to diabetes care and obesity and chronic heart disease. And the public health collaboration initiative has been using these alternative dietary advice and nutrition advice for several years now and having a massive impact on diabetes, either reversing the condition, reducing obesity, saving massive amount of money for the NHS in terms of reduction of drugs, but also reduction of cases of surgery such as amputation, which is a tragedy in itself. And it would be really nice to see that in this next 2020 to 2030 document, because there's lots of pressures to continue with the current outdated and frankly wrong guidelines on nutrition and diet. The food industry and the pharma industry will be wanting us to carry on prescribing drugs. Before drugs, people reduced sugar and they didn't eat potatoes and rice and stuff. And now that's starting to become a bit more popular because of the BBC programme, The Truth About Carbs. It's now, there's a kind of a momentum going. I think it would be great if this trust was one of the pioneers in helping people have better advice about reducing their risk of these awful chronic diseases, which overburden your health system anyway.
Okay, thank you very much. Okay, so maybe in the middle, do you have your hand up?
I was just going to say, no one's mentioned the amount on the budget that we will have to do all these things.
Okay. Thank you. Good question. Okay, gentleman here.
Can you hear me? Yeah, okay. My name is Colin and I too am not a councillor. I'm in the minority. Just going back to what the nurse said there about the hospital changes, the term district hospital. Basically that means it will be downgraded. with a view to be potentially sold off, but it's a stepping stone to possibly losing that hospital. My point is about the A&E, which is exactly when you lose an A&E, the hospital is downgraded. The A&E is the front door, it's the heart of a hospital. When you don't have an A&E, you don't really have a hospital as we know it. Nationally, the A&E 4-hour limit standards is supposed to be around 90%. 90% of people should be seen within 4 hours. And I think locally that's just about being maintained. However, the chief executive of Epsom and St Helier Hospital, Daniel Oakley's, his previous job used to be in northwest London, where he oversaw huge cuts and closures while he was there. Now his handiwork has left the results around about 35% of people are seen within 4 hours. So that's the handiwork of what he has done elsewhere before he has come to look after our local hospitals. So this is not a vision, this could be a huge disaster. The proposed acute facility that's being planned, if they can raise the money, and it's just as proposed, it will be a 4-year gap between the facilities being taken away from both hospitals and this possible new facility being built. At least a 4-year gap. So there's a good chance that after 4 years perhaps they might decide, hey, we don't actually need it after all. So I think we should scrap these plans. There was a previous incarnation called Better Services, Better Value, which also sounds fantastic, who could be against that? And this new proposal echoes those proposals. It's taking the 5 hospitals that we have and reducing it to 4 or possibly 3. They want to get rid of at least 2 of those hospitals. This is Better Services, Better Value, rehashed. We need to invest in both sites and help save all of our lives.
Okay, so we have about half an hour left. Are there any particular points that anybody from the CCG wants to clarify? Otherwise, what I would like to suggest, if you're comfortable with it, is that I appreciate that lots of people have had things to say. I also appreciate that not everybody necessarily wants to speak through the microphone, and I'd like to have some opportunity for people who haven't had anything to say to have a discussion at their tables. So I'd like to have some time for that, if people are comfortable with that.
There would only be one, which would be that I don't think it's right to say that we would ever close a hospital and wait 4 years before the new facilities were available, close services and wait 4 years before new facilities were available. So you'd be maintaining continuity of major acute services in the catchment throughout, and there are ways of doing that to make sure that those are always available. So just factually, I wouldn't want people to think that there would be 4 years where there were no major acute services in the local area, because that wouldn't be right.
Can we have that down as a pledge?
Okay.
And can we have the other pledge that there will be no reduction whatsoever in the number of beds? It's in their previous plan, about 2020.
Okay.
It's in their last plan.
So, I cannot speak to that. All we can say is that from the perspective of James today, what you've said is that you wouldn't close facilities before alternative facilities were open. And that's something he said today. I missed this gentleman over here who's been waiting, I'm sorry.
St Stephen's was closed before Chelsea Westminster was built.
Okay. So those are examples of other places. As you say, James has said something today. Let's see.
I'm very worried about the direction that the NHS is headed, and I have an example which is very relevant to the discussion this evening. And the example is of 3 A&E departments, one at Weston-super-Mare, which is a large town, and Bristol and Taunton. Now, what's actually happened is, this example is very relevant to what we're talking about this evening. They've closed the A&E at Weston-super-Mare from 8 p.m. to 10 a.m. So, if somebody has a stroke or a heart attack, they have to go 23 miles to Bristol, or they have to go to Taunton. Now, I don't know exactly how many miles, but it's a long way. So I think we need to have 3 A&E departments like we have now. I think closing one of them has got major implications for the residents.
Thank you. Okay, what I'm going to suggest is if there's anybody who hasn't yet had a chance to speak, stick your hands up. Oh, sorry. I'm going to take those 2 points here, and then I'm going to ask that we do have at least a little bit of time where those at tables who might feel more comfortable talking in that setting do have a chance to do that, okay? Okay, so this lady in the middle, and then I'm going to continue now.
Hello, I'm a constituent of Merton. I guess my nearest hospital is St George's, one of the best hospitals I've seen in this country. And you plan on threatening that. You plan on threatening to play Russian roulette with people's lives. St Helier, I was fortunate to have my son there 41 years ago. And I have had a few operations in the hospital. What wonderful care I had. That should continue. Most people in this room accept that the NHS is a part of the norm of their life. But there's a greater population coming along who are saying, NHS, well, yes, of course, that's not going to disappear. Because they never knew what the NHS was really set up for, and that was to support deprived people. And here we are, with our wonderful doctors and nurses, and people who specialised over the years, we are supporting all kinds of medical needs and prolonging life. Now, again, Russian roulette. We should be increasing our doctors and nurses, getting the money that's been, I've heard tonight, that was put aside by the previous Labour government. You do need to have a little bit of a juggle around, I think, and people need to be, in general, informed a little bit more about how the NHS money is spent. You go to the doctors, and I think it's fortunately, I'm a pensioner, I don't need to pay. That might all change. But I believe it's £6.80. But what is the actual cost of those drugs? Nobody knows. People need to be better informed. There's a very, very big playing field here. But please do not treat the people in this room, and many more, like idiots. Give us the facts that we need. Do not even entertain to close any of our services. Look to increase our services for the continuing growing population, and respect doctors and nurses that work hour upon hour endlessly to give us medical care.
Thank you. Thank you. Okay, so this lady just here, I'm just going to hand this to you.
Right, so I'm not used to doing the microphone. James, I just wanted to pick up on something you said about keeping the acute services for the catchment. One of my concerns is there's nothing about the catchment in this improving healthcare document. The Hospital Trust, when it did its strategic outline case, was very clear that if it went to Epsom, the catchment there would be 295,000. The current catchment is 490,000. If it goes to St Helier, the catchment would be 369,000. That's a lot less than that 490,000. And if it goes to Sutton, it would be 418,000, and that's still 72,000 people out of the catchment. Now, you may be changing that because you're listening to our questions. I really hope that's the case. And I take on board what you say about the consultants and the numbers, but I think what we all feel is that, as you say, that's a national decision how many are trained. Let's fight to change those decisions.
So just very specifically, what I mean is that there would always be major acute services available within the current trust catchment area, so across the three sites that we talked about. One of the pieces of analysis that we're doing that Andrew talked about earlier is looking at how patient flows might change under all the different solutions and how that might alter the size of the catchment. So we are looking at that analysis, and that is part of what we would need to look at as part of any decision-making process. So, you know, it is a really important consideration, and you're right to highlight it.
Absolutely, and I just wanted to be clear that that involves then buying in beds, paying for beds at St George's, paying for beds at Croydon, paying for beds at Redhill. You know, that is people who currently go to their local hospital who will not be going to their local hospital. And I've had to go with my teenage children, and it's a question I asked actually way back when this started actually at St Helier at one of the board meetings. When I go to A&E, I don't know what's wrong with my child. I turn up there and I don't know if they need a consultant, I don't know if it's all right to see a GP. If you move this, there will be district hospitals with urgent care centres, and there will be a separate site with acute consultants. I don't know who I've got to take my daughter to. And that still, for me, hasn't been answered. So that's a big concern I've got.
Thank you. Okay, so I think that's a helpful issue to raise actually, is how does that work in practice? I think we've captured that. Okay, thank you all. I am going to ask if we can just spend the last 20 minutes at your tables. I'm very conscious that there are people who we haven't heard from yet, and I would like them to have the opportunity to speak. There are facilitators at most of your tables, and the CCG staff will capture notes where they're on. There are post-its. You can write your own comments to us if there's specific feedback you want to give. And I will ask if you want to give. I'll hand out evaluation forms if I can finish. I'll hand out evaluation forms to ask for your feedback on these events because we want to do them better in future. And we'll try and capture that feedback where we can. The other thing that's helpful is a lot of this discussion has been about how this consultation would be different, can it be improved? And I think there are also a lot of issues raised about how we know that was working. So if you're able to tell us what would you regard as enough, what do you regard as good enough consultation, that might be something that the CCG is able to take on board. Okay, I'm going to hand you over to your tables for the last 15-20 minutes.